We are live.
Welcome to iFocus Online, episode 367 and 42nd on Oculoplasty module. Today, we have with us Dr. Tarjani Dave from prestigious LV Prasad Eye Institute, Hyderabad, to speak to us on orbital fungal infections. Dr. Tarjani Dave did her MBBS from Lokmanya Tilak Municipal Medical College and General Hospital, Sion, Mumbai. She did her MS from Sri Ganpati Netralaya, Jalna, followed by a specialized training in orbital disease and oculofacial surgery at LV Prasad Eye Institute, Hyderabad. She is currently working as a full-time consultant at LVPI and she has brought revolution in field of orbital implants. She also heads the Oculoplasty laboratory that has brought in many innovations to India, like the orbital tissue expander for congenital anophthalmia, osteointegration exentration prosthesis, and 3D printed customized implants for management of orbitofacial fractures and migrated orbital implants. She also has a specific interest in the physiology of ptosis, eyelid malpositions, and cosmetic oculofacial surgery. She has authored more than 60 peer-reviewed publications and book chapters. She is recipient of AIOC Best Poster Award 2011 and 2018. She has won also the AIOC Best Paper Award in Oculoplasty in 2018 and 2019 and an International Best Paper Award for Imaging in Thyroid Eye Disease in the year 2020. On behalf of our entire iFocus team, we welcome you, ma'am. Over to you.
Thank you very much, Ruju, for your kind introduction. I'm happy to see you, Mritika, and Shruti here, and thank you to the entire team at iFocus for having me with you. So, Ruju, tell me if this is all good.
Yes, ma'am.
Okay. So, good evening, everyone. We are going to go through fungal orbital infections and injectables that you use or treatment that you offer for these patients. I work at the Hariram Motomal Nasta and the Renu Hariram Nasta ophthalmic plastic surgery service at LV Prasad. And the structure of my presentation is to speak to you about two infections: aspergillosis, the role of voriconazole, that's the first infection; mucor, the role of amphotericin B, and what I have learned through the series of cases that I've been fortunate to come across and manage in LV Prasad Eye Institute. So I'm going to take you through 10 specific situations, 10 in aspergillosis, 10 in mucormycosis. And this is kind of going to be case-based, a very little, added tips with each case that I try to hand over to you via this lecture. You will see some full face photographs of my patients for which we have the consent in place, and we don't have any financial disclosures to make at this point of time. Now, when you talk of fungal diseases, the first thing that comes to mind is generally the patients are diabetic or immunocompromised because these patients are more likely to develop a fungal orbital or a fungal ocular infection for that matter. Fungal infection, as far as the orbit is concerned, is largely by the filamentous fungi, which is aspergillus, or you are likely to see infection by the mucorales group. The fungal infection, why is it so dreaded? Because it's considered life-threatening, especially when it takes an invasive form. If there is spread to the brain, then there are chances that the patient may lose his life to this fungal infection. And therefore, they generally warrant a much more rigorous approach to management than bacterial orbital disease. Having said all of this, you will tend to see more mucormycosis in patients who are diabetics and those who have undergone organ transplant. You are more likely to see aspergillus in patients who have severe neutropenia from some form of infection elsewhere in the body or some other form of immunodeficiency in the body. The cornerstone of fungal diseases remains imaging as well as microbiology and histopathology workup, which is going to clinch the diagnosis for you in most of these cases. Now, with this broad background, I'm going to take you through some classic fungal infections of the orbit. What do you see over here? This is a gentleman, probably in his early 60s. You see the right eye is proptose. There's fullness in the superior sulcus. Other than that, you clinically do not see any other signs. A little bit of ptosis, yes, but nothing else. And he is borderline diabetic. And he says that, I've been having this cough and cold for a long period of time. I went to my ENT surgeon. I have a previous scan that was done. He thought that maybe we should get a biopsy done. He did a biopsy from the nose. It's come as inflammation. I've used steroid and nothing has progressed for me in terms of improvement. And, I'm coming to you because now I'm very worried about my vision. I could read very clearly, but since the past 2 days, I'm not able to read clearly. So what are you seeing in this clinical picture? You're seeing that there is a gentleman who's immunocompromised, borderline diabetic. He has proptosis. There's no well-defined mass that is palpable. And then on the imaging that he has with him, he has a sino-orbital disease, which on a biopsy from the nose, which means the biopsy must be from somewhere here, right? From the periphery of the lesion, came as inflammation. He was treated with steroid. He has not improved. In fact, he says his proptosis has worsened and vision has dropped. So a sino-orbital lesion here, what do? You go ahead and you take a biopsy right from the epicenter of the lesion. So if this is the entire ill-defined lesion, its epicenter is somewhere here. And if this is the point where you want the biopsy from, the easiest approach would be to go transcaruncular, right in the center of the lesion, take out a chunk of tissue from here, send for microbiology and pathology, and lo and behold, it grows aspergillus. And then what do? You treat the patient with voriconazole. Since this gentleman also had decrease in vision from 2020 to counting finger that really was bothering him in a span of 2 days, past 2 days, we went all guns blazing, and we also injected voriconazole in his orbit in that same quadrant for 3 consecutive days. And this is his radiology 6 weeks after the initiation of treatment. So you can see that not only has his proptosis come down, but on radiology, you can see that the lesion has nearly disappeared from the orbit and he regained 20/20 vision. This is classic fungal granuloma, the way it presents to you. Now, there are certain situations where, you are in no man's land, where you have a case like this, which could be Tolosa hunt, which could be fungus. And you will always have your neuro-ophthalmology colleagues kind of constantly tell you that, I'm not very sure if this is Tolosa hunt or whether this is fungus, because the treatment is diametrically opposite. When you have an orbital apex as a result of inflammation or Tolosa hunt, you're going to treat the patient with methylprednisolone. When you have an orbital apex syndrome as a result of fungal infection, steroids are completely contraindicated. So these are situations where if there is some amount of sinus involvement, you probably want to take the help of your ENT colleague and take a biopsy from here, or knock down the medial wall and take a biopsy from the medial end of the ill-defined lesion, or probably go from the orbit and try and biopsy around the nerve, with all the risk involved of pushing this patient into complete total ophthalmoplegia forever. You want to biopsy and you want to prove that it is fungus. If you have known host factors, like this is a diabetic patient, he's been in ketoacidosis, and now he's developing a total ophthalmoplegia, you're kind of, pushed on the track of thinking towards fungal infections. But if you don't have those host factors and systemic history, then you're really in a doubt as to whether this is orbital apex due to Tolosa hunt or orbital apex due to a fungal infection. So you go ahead, you try to get tissue. If it does show evidence of fungus on microbiology and pathology, then you go ahead and treat this patient with antifungals based on what you are seeing on microbiology and pathology. And this patient was again treated with voriconazole and he did fare well. The third common presentation that you see in fungal infections is seeing a discharging sinus. So when you see signs of ophthalmoplegia with a sinus like this, and you have all the host factors that we spoke about, then this is very likely again to be a fungal infection. And again, taking a part of this pus and sending it would kind of, in most situations, prove it for you that it is a fungal infection. And then you go ahead and treat this patient with appropriate antifungals. So we've seen 3 presentations: the sino-orbital lesion, orbital apex, and orbit with a discharging sinus, which are very classic of a fungal disease. A fourth, this is the same patient with that discharging sinus who also has bone involvement over here. As you can see, look at the cortex and medulla on the uninvolved side, and look at that on the involved side. So while you have a discharging sinus medially, the disease is in the entire superior orbit involving the bone as well, which is also telltale of fungal infections. The fourth presentation is whenever you see involvement of the inferior orbit with an ill-defined diffuse lesion. You may not see sinus involvement, but if you go into the posterior coronal cuts and the inferior axial cuts, you will see some pterygopalatine fossa involvement. This is the area of pterygopalatine fossa. So if you see a mass in the orbit which is contiguous with the pterygopalatine fossa and seems to be extending there, you're again thinking of fungal infections. So these are classic common presentations of fungal infections. The same patient after treatment with oral voriconazole as well as injectable voriconazole in the inferior orbit. You can see that the proptosis has resolved. On radiology, the mass also seems to have reduced in size. So we discussed the sino-orbital, we discussed the orbital apex, we discussed presentation with a discharging sinus, and we discussed inferior orbital ill-defined lesions contiguous with pterygopalatine fossa. Now, there are certain situations where the fungus doesn't present in this classic textbook pattern that we have taught, and you do see some masquerades. For instance, this young gentleman, no history of any disease whatsoever, not immunocompromised, sudden onset of proptosis over the past few days, and there is a thickened inferior rectus as you see over here. Also a thickened inferior rectus on the sagittal scan. So what was done? A thought process of myositis was made. He was treated with oral steroids. But what happened? After 2 weeks, some response, yes, iffy, not very sure. But since there was some response, we thought that, okay, let us see if this really is non-specific orbital inflammatory disease, or is there something else going on? So we did do a biopsy from the muscle. Again, the biopsy was done from the periphery and it only showed inflammation. And then this patient was treated with methylprednisolone. And this is what happened to him following 6 pulses of methylprednisolone. There is some amount of residual proptosis on that side, but he felt he was better than presentation. And then he was lost for a follow-up of 3 years, after which he comes back like this. So what has happened? Over these past 3 years, what looked like just muscle involvement has progressed from 2019 to 2022 to have the entire orbit involved. You can see that the fat space which was visible here is not visible, suggesting that the disease has progressed. What looked like just inferior rectus involvement is now involvement all over the orbit. So what did we do? We went again in the safest zone, which is the inferotemporal quadrant of the orbit. You don't have any important neurovascular structures there. We kept ourselves away from the optic nerve, but tried to go within the center of that quadrant and take a biopsy from there, because the initial biopsy showed inflammation. Here, suspicion of fungus was high because he's worsened over a period of time. And yes, we did get aspergillus grow from this biopsy specimen. And he was then treated with oral as well as intralesional voriconazole. You can see that his proptosis has reduced. This patient is still under treatment. And the query that remains in such situations is, when do you actually stop oral voriconazole? So there isn't much literature on it. But on discussion with infectious disease specialists, what we've come to realize is that most of these patients tend to require oral antifungals for a period of at least 6 months since initiation of treatment. If clinical resolution of signs has not happened in those 6 months, then the oral antifungals are continued for a longer period of time. However, you cannot stop antifungals based on radiologic evaluation. On follow-up scans, you will always see some residual sequelae of the disease. It will never become clear, the orbit, and therefore you don't use radiology as a guide to stop treatment. You generally tend to use this guiding principle that for about 6 months, you want to continue the patient on oral antifungals. Now, this is another case here, ill-defined lesion in the inferior orbit. Everything else, sinus, absolutely fine. In fact, he was being treated as a case of thyroid eye disease elsewhere because of the eyelid retraction and the starey appearance that he had. However, this is nothing like a muscle in thyroid eye disease. This muscle has ill-defined. This enlargement is involving the medial rectus as well as the inferior rectus is ill-defined. This is a patient where you need to go in and biopsy and prove what it is and treat based on it. On biopsy, this again was aspergillosis, and again the patient has been treated with oral as well as injectable voriconazole. Certain weird presentations like this do come up when you tend to be a referral center. So this is a lady who just had a history of the left globe slowly not being in position. That those were her words, and what she meant is the dystopia that you see with these nodules that are coming up across several areas of her face. And we biopsied these nodules and it grew aspergillus. Before biopsy, obviously a radiology was done, and this is what I wanted to show you. There are certain fungal infections that produce splaying of bone. You can see that the bone is thickened here. It's not eaten up like we saw in the previous case, but there's thickening of the bone. And this again is possibly a radiological marker that there is a fungal infection going on here. Again, she was treated with oral antifungals. The nodules did disappear over a period of time, but new nodules kept cropping up, which had to be removed on and off. And she remained on antifungals for nearly a year, after which the dystopia did persist, but it was much lesser. And a clinical decision to stop the oral antifungals after a year was made, following which she's been maintained in this position for a pretty long period of time. She initially was on oral ketoconazole, but she did not have a good response to that, and therefore she was moved or shifted to oral voriconazole, with which the dystopia reduced a bit, and then after a year she was just followed up without any antifungals. Now, yet another case over here which looks like an eyelid abscess, but if you look at it closely, you don't really see the edema around the eyelid margin. If this is an abscess and not a mass, then you should ideally be seeing all the colored or rubor of a hot eyelid or an infective presentation. So again, it warrants a biopsy. And when a biopsy was done, it again grew fungus. And this patient again was treated with oral as well as intralesional antifungals, and he's responded pretty well to those. Now, this is again another weird presentation of a lady who was thought to have myositis because she had an enlarged extraocular muscle, as you see over here. She was treated with steroids, to which she did not respond, and therefore a muscle biopsy was planned. And after a muscle biopsy, it grew fungus, and she was again treated with oral antifungals. For some strange reason, when she did have the muscle thickening, the sinuses were clear, but over a period of time as she was treated, you can see the haziness in the sinus come up. So you can't really rely on this haziness to say that it is sinoorbital disease and therefore fungus. You may have patients with fungal orbital involvement where the sinus on radiology may appear absolutely clear. And then this is the last case in the aspergillus series that I wanted to show you, where again you have muscles enlarged, what looked on a cursory glance as medial rectus and possibly superior oblique involvement on detailed evaluation of scans is actually what? It's a sinoorbital lesion. So you might get carried away by this appearance, but it's always good to go ahead, and if you have any doubt, repeat a CT scan in patients who have an MRI because that's when the bony destruction will be very apparent to you. And you can see that there's no bone here in the medial wall, and it is a sino-orbital lesion. And again, this was biopsied transcaruncular aspergillus, treated with voriconazole, and that's how she is after a period of a year following treatment. So in these cases, what we've discussed is the classic presentation of orbital fungal granulomas, where you can see an orbital sino-orbital lesion, or a picture of total ophthalmoplegia with the apex involved, or a discharging sinus, or an inferior orbital lesion with extension into the pterygopalatine fossa. On imaging, you're likely to see these to be sino-orbital. CT has its role in telling you whether the bone is eaten away or not. MRI also has its role in telling you what the contrast uptake is like and whether there are any necrotic areas in the orbit. Largely a CT scan would suffice. These scans also tell you about what has happened to the bone in the surrounding area, which does get infected in patients with fungal diseases. We discussed the masquerades or the atypical presentations, and we discussed that you would need a biopsy specifically from the epicenter, because the periphery is likely to show only inflammation. And this biopsy needs to be subjected to both microbiology as well as pathology. And more often than not, you're likely to see aspergillosis or aspergillus grow. And the drug of choice in these patients remains oral voriconazole, which we said should be continued for at least about 6 months following initiation. In those patients where the fungal granuloma has actually resulted in vision, reduction in vision, or the granuloma is really extensive and you're worried about the vision getting affected or motility getting affected, you have a case for going ahead and injecting retrobulbar voriconazole as well, which is injected over a period of 3 days, every day 1 ml, and the dose is 3.5 milligrams per ml. So 1 ml of 3.5 milligram per ml voriconazole for 3 consecutive days, along with oral voriconazole in a dose of 200 milligram twice a day for a period of 6 months, is what is continued for most of these patients with fungal granulomas. I just wanted to highlight that at this point of time, we don't have very good markers, either clinical or radiologic or serologic, to tell us when the oral antifungals should be stopped. So this is one thing that remains as a gray area, but as a rule of thumb, like I mentioned, treatment for about 6 months seems to be working in most cases. So we switch gears now to mucormycosis. And this is one slide that I really like, which brings out, what has driven the treatment in mucormycosis. There is always a sense of urgency when you say the word mucor, because the fungus tends to rapidly progress from the sinuses to the orbit to the central nervous system. Sometimes the fungus can directly progress from the sinuses or the pterygopalatine to the central nervous system. And the reason why all of us fret with this diagnosis is the mortality rates are pretty high. These are patients who are immunocompromised, they are diabetic, they are likely in ketoacidosis, or they are immunosuppressed for organ transplantation, or they have leukemia, lymphoma, or some other malignancy. So they, as it is, are immunosuppressed. And to add to that, a fungal disease, which can be life-threatening, kind of brings in the urgency in these patients. The major takeaway from this slide for all of you would be that when you do have CNS involvement, the mortality can go as high as 80%. So your aim is to stop the disease from progressing to the brain. There are several fungi that fall in the order Mucorales. What you commonly see is Rhizopus and Mucor. These are the two commonest fungi that you see in this order affecting the orbit. And when you are thinking about mucormycosis, you will have to put all the constellations together. You will have to look at host factors about whether this is an immunosuppressed patient. You'll have to look at the clinical presentation. You'll also have to look at the examination findings, and you'll have to bring in perspective the blood counts of the patient, whether they have any diagnostic nasal endoscopy or swabs done that are suggestive of a fungal infection. So all this constellation together helps you in zeroing down on a diagnosis of mucormycosis. Whenever you're suspecting rhino-orbital cerebral mucormycosis, your imaging of choice is an MRI with contrast. This helps you in staging the disease, and once you've staged the disease, you want to have some tissue diagnosis to prove that this is mucormycosis. And this tissue diagnosis is usually a swab from the nose or tissue that is directly taken as an incisional biopsy or as debridement from the infected orbital or sinus tissues. And you can divide mucormycosis as possible, probable, and proven. Possible when you're seeing a constellation of host factors and clinical signs and symptoms. Probable when your MRI as well as nasal endoscopy both back you and tell you that, yes, this looks like mucormycosis. And proven when microbiology or pathology comes up and tells you that, yes, I can see mucor on this sample. So that's how you look at possible, probable, and proven mucormycosis. Now a little bit into imaging here. So this is the same patient who has had a CT scan and an MRI. This is a soft tissue CT. And what do you see over here? You see sinus involvement, right? And then the muscles look okay. This is the lacrimal gland. The orbit largely seems okay. But when you do a bone scan, you can actually see that in the region of the medial wall and the floor at the inferomedial aspect, there is loss of bone. This bone is possibly eaten away. So these windows help in telling you what is happening to the, or these scans, CT scan helps in telling you what's happening to the bone. Versus that, when you do an MRI and it's the same cut, what you see now is there's not only sinus involvement, but there's involvement in the extracornal part of the orbit as well. And when you add contrast to the MRI, you can actually say that the orbital involvement is involvement which is taking up contrast, which means blood is reaching that area of the orbit. It is not dead tissue because the contrast has reached there. So this is the importance of getting MRI with contrast. You'll be able to pick up very subtle orbital involvement in these patients. When you do inject contrast, you'll actually be able to pick up areas where the contrast does not reach. For instance, the entire superior ophthalmic vein in this patient is thrombosed. The contrast is reaching the periphery of the vein, but not within its lumen. And why is it not reaching there? Because mucor is known to produce angioinvasion, because of which it produces necrosis. Similarly, in this same patient, at the apex, if you look at this cut, you can see that there is an area where contrast is not taken up. And again, in the cavernous sinus, there is an area of loss of contrast enhancement. All of these are suggestive of areas of necrosis. So when you do see a hypo-intense area on MRI surrounded by hyper-intensity, hypo in the center, hyper around, that's an area of necrosis if it is a contrast-enhanced MRI scan. So that kind of covers the imaging that you would want for mucor patients. Now, broad management guidelines for mucor include that these patients actually, first of all, have to have a reversal of the immunosuppression. So if they are on any immunosuppression for organ transplant, you'll have to speak to that team and take them off the immunosuppression for a while. If they are diabetic, the diabetes has to have stringent control. With this, you introduce IV liposomal amphotericin B, which is the drug of choice for these patients in the induction phase. You give a little bit of bridge therapy, which means after 15 days of induction, you give the IV as well as oral. Oral could be posaconazole or isavuconazole, whatever the infectious disease specialist suggests. which is for a period of about 1 to 2 days. And then you have a step down phase in which all these patients are continued on oral treatment for a pretty long period of time, at least about 3 to 6 months in most of these patients. So that's the medical treatment that is initiated for every patient who has mucormycosis. What else do you do? You also need to clear off the sinuses of any infection, and then you need to manage the orbit and the brain. So if the orbital involvement is diffuse and there are large areas of loss of contrast enhancement, which means the whole orbit is a bag full of pus, you will exenterate that orbit. But if the orbital area involvement is limited, it's focal, the loss of contrast enhancement is only in one quadrant, you can go ahead and debride that area and inject transcutaneous retrobulbar amphotericin B, hoping that you will not have more necrotic areas. So you reverse the immunosuppression, you start medical treatment with amphotericin B and then go ahead with step down with an oral antifungal. You clear the sinuses and you treat the orbit based on the involvement in the orbit, whether it's focal or diffuse. So here is that same patient who I showed you again, who had diffuse areas of necrosis in the orbit, and she underwent an exenteration. But what happens to those patients who have a very small area of necrosis? Is exenteration really warranted? Maybe not. What you can do is debride that area of necrosis and make sure that the fungus does not overtake you by injecting amphotericin B in the surrounding orbital tissues, so that the fungus cannot replicate, it dies, and it cannot produce more areas of necrosis. So that's what we established with the help of the overload of mucormycosis that we saw following COVID. Now, these are 3 patients with their scans at the bottom. You see some amount of orbital involvement here. In fact, involvement of the cavernous sinus, it's also, and you see that the cavernous sinus is involved, so the brain is already involved. So are you going to be able to stop the infection from reaching the brain? No. Patient is presenting to you with this ophthalmoplegia. What are you going to achieve by exenterating this orbit? You may not be able to achieve much because most of this disease is taking up contrast. There are very small areas where contrast is not taken up. So what did we do? We debrided the medial orbit and we injected amphotericin B in this patient. Similarly, another patient who has involvement in the intraconal area, medial intraconal compartment, has fat stranding. Would you go ahead and exenterate? Possibly no. Possibly you could get away by just injecting tram. And yet another patient who actually has a frank brain abscess, the hypo and the hyper around it. So his area of necrosis is in the brain. Even if you exenterate the orbit, which means you remove all of this tissue, you're still not going to be able to remove the brain abscess. Again, we did not exenterate this patient and we asked the neurosurgeon to manage the brain, and we only injected tram for the orbit. And all these 3 patients are alive today. In fact, the first patient has 20/20 vision. The ophthalmoplegia has completely reversed. This gentleman needed a tarsorrhaphy to manage the ocular surface, but he did not require an exenteration. And so did the 3rd patient. They are all alive. They have not died from mucormycosis. We've been able to save their eye. In most of these patients, we've also been able to save their vision. So this is what you can achieve for these patients if you treat the disease based on the radiology, provided you've taken care of everything else, that the immunosuppression is reversed, IV antifungals are given to these patients, the sinuses are cleared, and then the orbit is managed based on the imaging features. Now, what happens once you've injected retrobulbar amphotericin B? So you're seeing another gentleman here. This is on presentation. This is after treatment. You see that area of necrosis in the superior orbit. Over a period of time, that orbit tends to show resolution. But in the initial period, after you've injected the drug there, you will actually see more inflammation or more white areas on scan immediately after injecting the drug. That's because amphotericin B is known to be corrosive. It produces a lot of inflammation in the orbit. So that increase in hyperintensity should not be read or interpreted as worsening of the disease. We've studied scans of these patients over a long period of time, and we've come to a conclusion that average time for the radiology to get back to normal, where you are not alarmed that there is an increase in hyperintensity, is about 6 months following stoppage of orbital injections. So that's the amount of time it takes for the imaging to come back to normal. And just to extend the discussion a bit further, disease at the apex is the one where you're really worried, because right now, with the disease being in the apex, it's only orbital and it's an impending CNS involvement. These are the kind of cases for which you're going to be pushed to perform an exenteration by the ENT colleagues, by the neurosurgeons, by the infectious disease specialists, because they do not want that fungus to enter the brain. Because once it enters the brain, the mortality rates are very high. Again, imaging comes to your rescue. And if you see a disease which is like this, where there are no areas of loss of contrast enhancement, you may not need to exenterate, and just injecting amphotericin B takes care of that patient. You can see that her ophthalmoplegia has kind of reversed. This image is just about 2 weeks after the injections have been given to her. But you can afford to perform all this treatment if all the remaining that we discussed, thorough sinus debridement, IV ampho-B, and reversal of immunosuppression, are instituted for such patients. So just to summarize, I've spoken to you about 2 categories of fungal infections. We looked at aspergillosis and the role of voriconazole in its management, and we've looked at mucormycosis and the role of amphotericin B, both IV as well as injectable in the orbit. And with the help of these cases, I hope I have given you some pieces of information in how to manage orbital fungal infections. Thank you so much, everyone. This is just the last part of it, which summarizes every aspect of what we've discussed today. And thank you again.
Ma'am, it was such a wonderful session, and specifically you made it so interesting with case presentation, and with each and every case you like gave us useful tips how to manage it, and covered the entire spectrum as well. And I remember you have inspired me during my residency days with IPEF. And today, I hope you have inspired many more residents like me through this platform. So thank you so much, ma'am, for that.
Thank
Now,
you.
if you
Absolutely. It was a wonderful, wonderful lecture, ma'am. Thank you so much.
Thank you, girls.
Now, if you permit, ma'am, I would like to take few questions which we have received through different social media portals.
Yeah, please go ahead.
Yes, ma'am. So how to approach a case of probable fungal granuloma previously treated with steroids? Like what should be the ideal steroid washout period, and what should be the ideal way of management?
Right. So typically we say that steroid has a half-life of about 3 weeks, and it washes out in that period. So you want to give about a 3-week steroid holiday, after which, and you need to explain to your patients that in those 3 weeks, they may see some signs of worsening, for which they should relax. And then after that period, you go ahead and perform a biopsy. When you do perform a biopsy, 2 things that we don't always do. One, send for PCR for fungus, because it has a higher rate of picking up fungus positivity. And second, if you're suspecting a fungal disease, with so many fungal infections being treated post-COVID, there is some amount of drug resistance that is coming up recently. You should send the specimen for antifungal sensitivity. So PCR and antifungal sensitivity are 2 additional tests that you want to do on the microbiology side. When you send for antifungal sensitivity, the sample has to be in a bottle without any saline or without any formalin. And the microbiologist would immediately have to place it into the discs for the disc diffusion method, where they tell you the sensitivity to several antifungal drugs. Besides this, it's always important to send tissue for pathology. There are several cases where the microbiology positivity rate is much lesser than histopathology actually showing you fungal filaments. So I would always send tissue for both of these. And then if I do get tissue diagnosis that this is fungus in any form, whether I see fungus on KOH smear, calcofluoride, or fungus has grown in culture plates, or it's grown in PCR, or the pathologist is telling me that there are filaments, then I would go ahead and treat it as a fungal disease.
And also one question I have from my side is, what if the patient the inflammation and all flares up during the steroid washout period? How to manage those symptoms?
You can treat the patient with non-steroidal drugs if the inflammation does worsen in that period. Typically, this is in the aspergillus spectrum, Ruju. For mucor, you don't really wait and do any of this. You go all guns blazing and you're fast. And aspergillus, from all the images that I have showed you, very rarely presents with inflammation. It's usually a quiet eye. So you're not very worried about the inflammation really worsening in these patients.
Okay. Next question we have, ma'am, is the role of multi-level incision biopsy.
Right. So it's now, and I know I've learned this from Dr. Honavar, that when you perform an incision biopsy only from the periphery, you are more likely to see inflammation and fibrosis. And it's always the epicenter of the lesion which is most representative, whether it's an infection or a tumor or anything else, which ends up giving you the correct diagnosis. So for situations like infections and tumors where you really don't have a clinical radiological hunch and you're depending on pathology to prove it for you, you should always go ahead and get biopsies from multiple levels. The peripheral, the superficial part is not really that important. It's that epicenter which is going to clinch the diagnosis. So get a deep biopsy.
Next question we have, ma'am, is the role of empirically starting antifungals along with antibiotics in case of acute presentation of orbital cellulitis.
So typically, as a policy, we institute antifungals only when we have tissue diagnosis. We don't empirically start antifungals.
And ma'am, like how to approach a case of Tolosa-Hunt syndrome? Like when do we go for a biopsy?
So if you have a classic typical Tolosa Hunt, where the involvement is at the apex, and there is absolutely no involvement in the sinuses, you go ahead and treat the patient with steroids. But when you see apical involvement, ophthalmoplegia with some fuzziness in the sinus, probably a host factor, say the patient was diabetic, or say he's undergone an organ transplant, or maybe he had leukemia for which he's treated. All those cases are cases where you might want to get a tissue diagnosis before treating the patients with steroids. Getting tissue in Tolosa Hunt is extremely difficult because that tissue is right at the apex where all your important neurovascular structures are. And that is the situation where endoscopic skull base, medial wall removal, and some amount of tissue from the base of the skull and the orbit might help you in getting the diagnosis.
So management along with a neurosurgeon might help us to reach the diagnosis.
Yes, with an ENT surgeon and a neurosurgeon.
Regarding TRAM, like the number and the frequency, how to decide?
Right, so TRAM is very, very corrosive. Voriconazole is not so inflammatory. Amphotericin B is very inflammatory. What has been described in literature is 3 injections. So you give 3.5 milligram per ml on 3 consecutive days. If following the first injection of TRAM, you do see compartment syndrome, then you can give a drug holiday for a day or two till the compartment syndrome resolves, because these are patients where you're suspecting fungal infection. So you don't have the luxury of treating the compartment syndrome with steroids. You might have to resort to canthotomy, cantholysis, and let the inflammation settle down. And then you give the subsequent 2 injections. But typically what you do is 3 injections. I
And
also, because you asked this, want to make an additional point that in all our cases, and we've recently completed this study, that in all those patients where an orbital wall was knocked off, was decompressed during the sinus debridement, and we injected tram, no compartment syndrome developed. So you might want to have a word with your ENT colleagues, because most of these patients require sinus debridement. So when they're performing the debridement, it's a good idea to knock off the medial wall, because when you inject tram, you're not going to be worried about compartment syndrome. And patients can actually lose vision from the compartment syndrome rather than from the fungus.
Ma'am, apart from compartment syndrome, have any other complications been noted with tram?
Largely, no. It is an inflammatory drug, and the only complication that it can produce is a compartment syndrome. Well, that compartment syndrome can lead to vision loss. It's not really the drug producing vision loss.
And the last question we have for you today is how to manage a case of candidiasis.
I haven't had the opportunity to manage any orbital candidiasis, but I think that would be something that I would kind of take help from the retina colleagues, because they tend to see much more intraocular candidiasis than we see. So I don't have any experience in managing candidiasis, unfortunately, at this point of time.
Dr. Mritika, would you like to add something?
No, I think she covered the topic beautifully, and I think she highlighted a lot of important things, like the importance of collaborating with different departments, the role of PCR, and asking specifically for drug resistance in these cases. And of course, the important difference, and how to go about with the management whenever there's diagnosis of differential diagnosis of Tolosa Hunt in picture, because that is something that we get stuck with. So thank you, ma'am. We won't keep you any longer.
Thank you.
Have to be there. Yeah.
So before we call it a day, I would like to make a small announcement. Next, we meet on Wednesday, that is 3rd of January 2024. And we'll start this new year with parasitic orbital inflammations. And to speak to us, we will have Dr. Maya Hada with us. Thank you so much, everyone. Good night.
Thank you. Happy